All right, good morning. We're live. So welcome to Seinfeld, where this morning's discussion will focus on the heart attack. So where would the group like to start?
I think probably with the focusing matter on George.
George?
So he seemed very convinced that he did have a heart attack when it was actually just, my understanding was it was his tonsils that overgrew. And Jerry said that it was probably because of the documentary he watched, because he had a similar reaction to when he watched the anorexia documentary. And based on how he was interacting with the doctor in the hospital, I was just like wondering if he had illness, anxiety disorder, or if it was like psychosomatic or something else.
Yeah, good. All right. So perfect lead in. So you read the cue card perfectly. Great job with the teleprompt. It gets us to the conversation that this particular episode always carries us to, and that is how to address a situation, a person that presents with a chief complaint of, fill it in here, for which no physical signs or symptoms, physiology would support your chief complaint. Okay. So I think the first step in approaching such a complex situation would be to arbitrarily have a consensus of what the term psychosomatic means, right? Because it means different things to different people. Today, and I'm not going to put anybody on the spot today. Usually in a class situation, an actual formal didactic, I would actually go around the room and then expose everyone for misleading or maybe even promoting the stigma of mental illness. I'm not going to do that here. So the easy answer here is that psychosomatic illness is nothing more than any illness that is biopsychosocial, right? With the psycho part of psychosomatic being the psychosocial, the somatic, the bio, right? So having said that, that means that since every single illness ever described since Aristotle is biopsychosocial, so too then is every illness psychosomatic. Every illness has both psychological and somatic components to it. I defy you to name one that isn't, right? That's rhetorical. That's do not even try, right? A person comes to you for help. They actually make an appointment to see you, and you can't find anything that will guide your case formulation or treatment planning for the somatic portion of their psychosomatic illness, be it whatever it is. At that point, what is the only thing you can do as a healthcare provider to increase your patient's overall sense of well-being? Assist them on the road to recovery from whatever it is that they're struggling with. If you can't do anything for the somatic component, what is the one thing then that you can do next for them?
Help them with the cycle.
That's that simple, right? Once you adopt that perspective, once you adopt that role, the term that we borrow is psychogenic illness, right? The idea here is that since you're unsuccessful in identifying the somatic component, that must mean that the psychological or psychiatric aspects are deemed to be central in the exacerbation or perpetuation of the illness. And when that happens, that is the very definition of a psychogenic illness. Now, trick question. This one, I'm going to put you on the spot. Trick question. At this point of our little algorithm, our flow of ideas and coming up with a case formulation of that patient, who then is in a situation to make the diagnosis of a psychogenic illness? Given what we just discussed.
Wouldn't it have to be, we'd have to do a rule out of pretty much everything. We'd have to rule out that his troponins are negative, that he doesn't have any changes in his EKG. I don't know if we want to rule out a Lexi-scan or if that's just like too.
So you're going back to the case study of George Costanza.
Yeah.
And that's perfectly fine. That's why we actually assign these episodes to do just that. Who then, generally speaking, is in a position, maybe the characters are not necessarily in the episode, who is in a place to diagnose a psychogenic illness?
Yes, I would say it would be like a partnership between the primary doctor and then the psychiatrist, because you need that medical component to either so rule all the other sides there, but then I think the psychiatrist would be helpful to diagnose psychogenic.
So I'm gonna just ignore the very last thing you said, because everything else you said was exactly correct. And that is anybody but the psychiatrist. Right? Anybody but the psychiatrist. If a psychogenic illness is defined as that psychosomatic illness for which no somatic component can be discovered, it's anybody but the psychiatrist that's in that role to get to that point in our algorithm, our flow chart right now, to diagnose a psychogenic illness. Now, once the psychogenic illness is in fact diagnosed, guess who's being called? I think that's your point, right? And the role that we have now is to put a diagnostic label on that psychogenic illness, diagnosed by our partners in internal medicine, cardiology, etc. Right? The first thing that we must consider is what? Now, it's always safety, right? After safety, for the psychiatrist now that has been called, perhaps consulted, what is the very first thing, not that necessarily we're going to ask our patient, but in terms of breaking this down and case formulating, we're going to have a little fork in the road here. What is the one thing we have to have answered at this point in our case formulation? And the answer is whether the individual, the patient, is providing misinformation. Right. And let's bring it back to George here, because, and I'm going to ask this question or re-ask this question in a very specific way. Is there any evidence that George Costanza in the heart attack is misrelating his symptoms in any way, or relating them in such a way as to deceive us?
Was he listing off the symptoms?
He was. Did we catch George Costanza in a lie? That's the other very straightforward way of asking the question. Because if the answer is no, then he's not lying, even if he is. That is, the default must always be no. We always have to give this patient-centered medicine. We always give our patients the benefit of the doubt. And if there is not discrete evidence that this particular patient named George Costanza is lying to us, is deceiving us, is misinterpreting his symptoms and relaying them to us, then the answer is always no. Okay, so is George Costanza misinterpreting or misrelating his symptoms to us? Yeah, so it doesn't seem like there's evidence. Now, hypothetically, if we would call Larry David and say, listen, we're in the middle of a didactic here. Can you please rewrite the script? Can you please edit the script? So the answer would be yes. What is if Larry David were to comply? And it's a cool dude, he probably would. For teaching purposes, let's say, in fact, no, we actually see that George Costanza, when nobody is looking, is doing things, rehearsing lines. And we actually see that he is, in fact, misrelating his symptoms. What is our differential diagnosis as to what ails George Costanza in the heart attack? Perfect. That's it. Right? Malingering versus factitious disorder. Both are misperception symptoms. I struggle with the wording. The DSM, the American Psychiatric Association, incorporates specific wording in the definition, but there's misrelating one's symptoms. So politically correct, perhaps even medically correct way of saying lying, deceitfulness. That said, what differentiates malingering from factitious? And neither of which are evident in the script, the heart attack, but instead in our little world of the revised script, thanks to Larry David this morning.
For factitious, it's to be in the sick, the motive is to be in a sick role. Whereas for malingering, the motive is usually to get out of something.
Yeah. And this all boils down to external gain versus internal gain. Right? If the gain is external, if George presented with workman's comp papers, with a benefit application, with you name it, boy, this looks like it's going to be malingering, or at least prior to 2013, the condition formerly known as malingering. The DSM is trying to phase out the terminology. On the other hand, in the absence of such information, the default is always that there is no external gain. If you can't find it, it doesn't exist. We have to give our patients the benefit of the doubt. So it's always factitious until proven otherwise. That there's something internally or subconscious that is going on. that results in the patient deceiving us or attempting to deceive us. Factitious versus the condition formerly known as malingering. Any questions about this side of the algorithm that we're building?
So as a clinician, which one would be, I guess, have like a worse prognosis in terms of?
Factitious. Factitious is a real illness. Malingering is not. That's why the DSM is phasing it out. Yeah. All right. Do any of these apply to George Costanza in the heart attack? No, so we have to go on.
So he went into the, I think the alternative holistic medicine, so would that still constitute trying to be in a circle, or he's just like very anxious?
If he's not lying to you, we can't even discuss factitious versus malingering. If there's no evidence that he is making a conscious effort to deceive us, we're not here. Right? Remember, it's that one question that gets us down this proverbial side of the algorithm. And without evidence, we're always going to go down that opposite side of the algorithm. And here our differential is twofold. The individual is presenting with signs and symptoms for which the somatic component cannot be found. All right. Therefore, they are struggling with a psychogenic illness, and without evidence that they're making a conscious effort to deceive us, our differential really is twofold. What are the two conditions that we must now consider? Well, that's been ruled out. Remember, the organic or the somatic part has not been discovered. Yeah.
Conversion disorder?
Conversion, good. Or?
Well, not illness anxiety because it manifested. So.
Perfect. Somatic symptom disorder is that condition in which an individual presents with one or more somatic symptoms for which no somatic or physiologic process can explain. It's that simple. Conversion is that variant, that subtype of somatic symptom disorder when their presentation focuses primarily on voluntary motor and or sensory deficit. Right. Unfortunately, conversion has a prevalence that the American Psychiatric Association pulled it out from somatic symptom disorder and created its own freestanding diagnosis. Otherwise, conversion is a type of somatic symptom disorder. Okay. There's your differential diagnosis, right? In each of these situations, the individual is not making a conscious effort to deceive you. They truly believe what they're feeling is real. Okay. Yet, neither may apply here. Because it looks like George is struggling with an anxious component, that he's very preoccupied with having an illness, and maybe doesn't truly believe that he has one, right? It's a fine line. But it's a fine line that the American Psychiatric Association does in fact investigate, because illness anxiety disorder, that condition, formerly known as hypochondriasis, is one that is now found in the anxiety disorders chapter of the DSM, or at least it will be with a subsequent revision. Right? So keeping this differential for the somatic symptom and related disorders chapter the way we have it, easy, 2 + 2. Let's look at this other condition, a related disorder, but one that is better categorized as an anxiety spectrum disorder, right? And that's called illness anxiety disorder. Right? Now, again, a little bit of a, brief background here. There was another condition published in this chapter called body dysmorphic disorder, which is another preoccupation illness. Individuals with body dysmorphic disorder had a preoccupation with an imagined defect in appearance. Because of that preoccupation, that thought, and the fact that the thought creates clinically significant anxiety, in 2013, the APA took this condition, body dysmorphic disorder, and recategorized it in the anxiety disorders spectrum, specifically in the obsessive compulsive and related disorder chapter of the DSM-5. For whatever reason, they did not do the same thing with illness anxiety disorder, but I think for test-taking purposes and learning purposes, it's best that you do that. Because I think in the DSM-6, you're going to see the same type of recategorization of illness anxiety as an anxiety disorder. Kind of makes sense. And it makes this workup of the psychogenic illness even easier, because now you have an easy 2 and 2 in terms of your differential. So You mentioned illness anxiety right from the outset. I wanted to provide the didactic and how you got there. And that's the way I would strongly encourage, especially consulting psychiatrists or budding psychiatrists that make up a consult team to go through the actual steps to arrive at a diagnosis like illness anxiety disorder, where the focus becomes not necessarily one's symptoms that physiologic process doesn't explain, but instead the anxiety incurred and the preoccupation with having a serious illness. And that's where I think George Costanza is.
If you come to the conclusion that it's one of these psychogenic diagnoses, how do you bridge that conversation with the patient appropriately?
Yeah, so I would actually borrow from history. All right, so years ago, decades ago, a lot of individuals were asylum because of hysteria. And then once some physician discovered reversible airways disease and ultimately the beta agonist. And all of a sudden, all of those patients with asthma were no longer put in asylums. And if you remember that, you could have a little bit of humility when you actually break this conversation and broach this conversation with a patient. Right now, I don't fully understand what's going on physically. But as we continue to figure it out, there's still stuff we can do. And that's the focus on how this must be affecting you, right? That is different than telling a person this is all in your head, right? Which is no part of the conversation ever, right? So that's the way I would usually broach it. All illnesses have both psychological and somatic components. We're working on the somatic. We don't have an answer for you today. Now, the good news is that there's nothing life-threatening. That's the good news. We'll continue to work. There are other tests, there are other consultants we're going to want to speak with. While we're doing that, I do not want to delay how this must be, or addressing how this must be affecting you. So I'm also going to ask a consultant, a friend of mine, to come in and talk to you about what their role could be here, right? And then you're going to get a call from the front desk, and one of these budding psychiatrists / third-year clerks are going to be at your bedside, right? So, and it's okay for you to reframe that too, right? Because sometimes the consultant may not have made that, or the consulting requester may not have made that clear. So it's okay for you to readdress your role, right? Any other questions or observations about George?
Very, I guess, insistent on finding diagnosis, like just something that I mean, it ended up being the tonsillitis, they was like asking one thing after the other. Lupus, is it lupus?
Yeah. Illness anxiety disorder. Yes, that's a function of anxiety, and of course that is incorporated in the very root of illness anxiety disorder. Yeah, no doubt about that. It's a preoccupation with having or acquiring a serious illness. And that's what we see here. George is not presenting with symptoms that don't have any, underlying cause. His focus, his anxiety, his preoccupation with that I think is the real focus of clinical attention. Hence why he doesn't have conversion and he doesn't have somatic symptom disorder. Single best answer here would be illness anxiety. I mean, you were right within 7 seconds.
I think it's interesting that he decided not to stay at the hospital and go the holistic route. And he was like, I guess like maybe he's because he's like, I guess like has illness anxiety, maybe has a lot of experience with hospitals and maybe some mistrust. But I was surprised that he so quickly is like ready to like not trust the hospital. I know that there's obviously a financial thing, but it's like I thought he was like one of so long to stay and do something like that.
Yeah, so George, and we could, I know this is an early episode, season 1 or 2, and there's another 7+ seasons to go. But George does show a pervasive pattern, an enduring pattern of that personality trait. He does have traits consistent with the obsessive compulsive personality disorder. He's very frugal. He has a miserly spending style. Now, I don't think he has OCPD. He's actually a little bit of a slob. He's in the opposite direction. Jerry is the one that's tightly wound, top buttoned, perfectly manicured. Jerry is obsessive compulsive personality, but it's very interesting. that these two are best friends because George is the exact opposite of Jerry, yet there is some overlap nonetheless. And while Jerry is not frugal, George has that quality of the obsessive compulsive personality. It's not only in this episode, and of course it's fostered here by Kramer. George is very dependent on others and what they think of him, so he's very gullible. And Kramer's role here cannot be understated. But it is George that has that enduring pattern of behavior over the 9 seasons of the situational comedy.
He seems well intentioned, but like it's just like the wrong execution.
Yeah, he's odd, bizarre, and likely cluster A personality. Yep. I want to talk about Tor a little bit. We only have about 4 minutes left. What do you think of Tor? Speaking of odd and
Is that from the holistic killer?
Yeah.
Really strange.
Yep.
I think for me as a pharmacy student, I was like, that part was most interesting to me when he went to the holistic healer. And then like the toxicology component of whatever was in that tea, the couch grass, and then I forget what the other component was, but whatever, I was curious what like the toxicology would be in that tea because
we should look it up.
he turned purple.
No, what we should do, we should just rewatch that clip, get the actual names, and let's call your supervisor and farm today and see if we can't find out. They'll question your integrity and what you're doing on site, but that'd be fun. Yeah, I want to be there when you call them. Having said that, Tor does make a comment, and this is one of the things I wanted to bring up because this does connect directly to our noon lecture or noon discussion on the Mothman Chronicles. Yeah, and that is he talked about living in the Arctic and how people that he lived with, would all of a sudden run into the snow and stick their heads in the snow. Anybody think to look that up because that does seem like bizarre behavior and might be behavior that would come to the observation of a psychiatrist. That's called piblokto, which is otherwise known as Arctic hysteria. So, and it's usually in individuals with no prior psychiatric history who spontaneously will run out into freezing temperatures, screaming, and stick their heads in the snow. So he'd actually describe something that is published in literature. Piblokto does appear on shelf exams. It is a form of an example of a culturally bound syndrome. And so I just want to kind of frame where we're going with this when we talk about the Mothman Chronicles at noon today. And that is when you take a test, a shelf exam, and you see behaviors that are geographically isolated. Your differential will be culturally bound syndrome versus a culturally sanctioned behavior. And both are subheaders found in the DSM. While both of these conditions have that overlap of being geographically isolated, in this case, the Arctic Circle, you obviously have to know what differentiates one from the other to get the single best answer on a shelf exam. For a culturally bound syndrome, even within the culture that it is bound, it is considered to be abnormal. And that is piblokto. So the vast majority of the time, 90% of the time, 90 plus, on a shelf, the question stem is going to ask you for the name of the syndrome that is being described in your case vignette, Arctic hysteria. On the other hand, when we look at culturally sanctioned behaviors, they also are going to be culturally bound. They're going to be geographically isolated, but within that culture, it's considered to be normal behavior. 60-40. 40% of the time, you may be asked the question stem to name the behavior. However, 60% of the time, you're going to be asked what is the next best step, and it is to do nothing. Reassure. Nothing further to do. Relay that it's normal. So 60-40. They want you to uncover that this is a culturally sanctioned belief or behavior And the majority of the time, 60% of the time on a test, the answer is to do nothing, but reassure. On the other hand, they might ask you the name of it, although I think that's gonna be less than 50% of the time. One example, and this is a movie that I did not assign, but is on my short list of the best movies that nobody's ever seen. The Skeleton Key. Terrific movie to demonstrate the culturally sanctioned behavior that is geographically isolated to the Southeast United States called root work, otherwise known as hoodoo with an H. The use of spells and magic to keep away evil spirits, hoodoo or root work. So that's an easy example of culturally sanctioned behavior that's sanctioned in the Southeast, the Bayou region of the United States. So I'll leave it there. We're only a couple minutes away from the bottom of the hour and our table rounds. So we'll meet everybody back at noon to discuss the Mothman Chronicles and talk a little bit more about these culturally bound syndromes. Thank you.